All right, a very good morning. My topic today is melioidosis, the great mimicker. So as an introduction, melioidosis is caused by Burkholderia pseudomyeli. It's a facultative intracellular gram-negative bacteria. It is an environmental saprophyte and it's found in fresh surface water or soil, and there are certain endemic regions around the world. And if you look at Malaysia, we are certainly endemic. All right, let me show you how this organism looks on the culture plates. So what we see here is actually called ash down media, right? On the ash down media, you get these pinkish, purplish colonies that appear wrinkled. This is the classical textbook description of Burkholderia pseudomyeli on the ash down media. All right, and this Burkholderia pseudomyeli, it's very difficult to differentiate it from Burkholderia capacia when you use ash down media. So in Malaysia, locally, a lab technician or MLT who is now retired, Alex Francis, came up with this Francis media, where in his media he is able to differentiate Burkholderia pseudomyeli from Burkholderia capacia, and within 18 to 24 hours you can actually start seeing a growth of pseudomyeli. So in Francis media, you get yellow haze-like colonies appearing on the first and second streak, and usually this indicates that it is pseudomyeli growing within 18 to. Let's look at melioidosis in Malaysia, its incidence, right? So all these states, Kedah, Kelantan, Pahang, Johor, and also Sabah and Sarawak, okay, they have submitted information or data with regards to their incidence of melioidosis. But of all these states, right, majority of the cases were reported from Pahang and Sabah. Also probably because they have a very good registry for melioidosis, and so a lot of information comes out of Pahang and Sabah. This is as of 2018, February 2018. So in Malaysia, although we are endemic, we see more cases coming. Alright, let's look at the global distribution of Burkholderia pseudomyeli and melioidosis. Okay, as you can see, the red color on the map, these are highly endemic areas, and yes, we are highly endemic. Malaysia, Peninsular as well as Sabah Sarawak, and the Northern Territories of Australia. It is a highly endemic area. However, if you look at endemicity, the whole of Southeast Asia is actually endemic. Okay, it is endemic for melioidosis. Okay, let's look at the impact of melioidosis globally. Alright, in 2015, Derek et al. Did the statistical modeling of clinical and environmental studies, and they estimated that there were 165,000 melioidosis cases globally with 89,000 mortalities. These are really huge numbers lah. All right, and it's also very important to recognize that one of the major causes or leading causes of morbidity and mortality in Southeast Asia and Northern Australia is melioidosis. All right, let's look at the risk factors that contribute to melioidosis and also the mortality. All right, so if you look at this study by Hassan et al., okay, in 2010, he has said that diabetes constituted the major underlying risk factor for developing and dying from melioidosis, okay, as illustrated on this table, yeah. And 57% of all primarily diagnosed melioidosis cases, that means it doesn't matter whether they cultured positive for melioidosis or not, okay, they were all positive for diabetes, as you can see here. All right, and this number was actually proportionately even higher among the culture positive cases. That means it was 71 or 72% of those who cultured positive for melioidosis actually had diabetes, right? And this was actually statistically significant, and the mortality in this group as well that cultured positive for melioidosis was 41%. So very high mortalities. And if you go on to look at the table, he does list other risk factors, but perhaps because the numbers were much smaller, they were not statistically. Okay, this slide, my aim of showing this slide is actually to discuss the incidence rates and looking at various countries, including Malaysia, where we have data from 3 states, namely Pahang, Kedah and Terengganu. So if you look at the incidence of melioidosis recorded for Kedah, it is pretty high at 16.35 per 100,000 population per year. And it's much higher than the rates recorded in other sites within Southeast Asia. If we look at the Northern Territory in Australia, the rate is also quite high at 19.6 per 100,000 per year. And if you want to give justification for this high incidence, perhaps we could tally it with the high rainfall, which is a common environmental factor that may underlie the high incidence observed in both in Malaysia as well, especially in Kedah and also in the Northern Territory of Australia. Okay, besides that, I would also like to show the mortality rates. Okay, Kedah with a 16.3 incidence per 100,000 has a mortality of 34%, whereas in Pahang, the incidence is 6.1 per 100,000 population and the mortality is 54%. Even in Terengganu, the mortality is almost half, that is 53% as well. The other thing that this chart I think strikingly shows is those patients from Malaysia, the data from Malaysia, 90% from Pahang, 50% from Kedah and 88% from Terengganu, all of them had bacteremia as a major presenter. Okay, I want to bring you back to Lubuk U in Maran, Pahang. If some of you may remember, in 2010 there was a drowning case, a victim who drowned, and there were about 150 volunteers who actually helped out in the rescue operations. They were from various government agencies, the fire department, the police, and etc. So of these 150 volunteers, 20 of them ended up with acute febrile illness after the rescue, and of the 20, 10 of these persons actually cultured positive for melioidosis. And interestingly, 4 of the 10 who cultured positive for melioidosis were also leptospirosis positive, and 3 out of 4 persons had melioidosis and leptospirosis co-infection ended up as a mortality. And totally, out of this rescue operation, 8 out of 10 persons died. It's actually a very sad story. It looks so serene, the place looks so serene and nice in this picture, but actually it has a very sad story that follows it. So this was reported as a case report by Hao Soon Hin et al. Okay, of all the 4 who died, all right, look at what their comorbidities. What strikes you the most? Diabetes. 4 of them, all 4 of them had diabetes. Of course, they were smokers. 3 out of the 4 were smokers, and they had other comorbidities like IHD and whatnot. But diabetes, every single one of them had diabetes, and 2 of the 4 actually developed ARDS as well. Okay, now transmission of Burkholderia pseudomyeli, or how does it occur? So melioidosis can be transmitted by these 4 methods: percutaneous inoculation, inhalation, aspiration, or ingestion. Now, early literature suggests that inhalation is probably the primary route for acquisition of Burkholderia pseudomyeli. Example, in soldiers who inhale the dust that is raised by helicopter rotor blades, and these are actually reported as papers from Vietnam. Okay, we also now understand that the predominant mode of transmission is actually percutaneous inoculation, and more so during wet seasons when the soil is wet or through contaminated water. Okay, and the other thing that is actually now more commonly understood is when we have these presumptive inoculating injuries, subsequently we notice that patient gets pneumonia, and then develops the patient develops pneumonia, most likely it is now said that there's a hematological a spread, and that's how the patient ends up with from a percutaneous inoculation ends up with a pneumonia through this hematogenous spread. And if you look at seasons when there's heavy rainfall or or there's a tropical storm or cyclones, at this point the mode of transmission then moves from inoculation to inhalation, and inhalation becomes a primary mode for transmission of Burkholderia pseudomoli. So rainfall in the 2 weeks preceding the onset of symptoms may actually become an independent risk factor for pneumonia or pneumonic presentation, septic shock, or even death. Okay, and during the 2004 December tsunami in the Indian Ocean, there was actually a large association with aspiration events, near drowning events, and through the inoculation of this organism in the setting of lacerations and also near drowning events, they actually end up with severe melioidosis, and some have even died from the disease. Alright, let's look at associations between activities related to routes of infection and clinical manifestations of melioidosis. So in this paper by Lim et al., they look at activities related to skin inoculation, and they found that it was actually negatively associated with bacteremias. However, activities related to inhalation were actually associated with pneumonias, and those activities related to ingestion were actually associated with bacteremias as well. The incubation period for melioidosis, in literature, they say inoculating injuries can take up to 1 to 29 days for the symptoms and disease manifestation. The mean is around 9 days. When we say 1 day, usually is seen in aspiration from near drownings, that within 24 hours the person can develop symptoms. So there are many factors that influence the incubation period. The 4 main ones are listed here. Inoculating dose, that means the amount of the bacteria that actually enters into the body is important, and the mode of transmission. So as I mentioned, if it's an aspiration, then the symptoms occur very much faster. Also, the risk factors of the host and the variable virulence properties of the isolate becomes important. All right. So now let's look at how we define acute and chronic infections in melioidosis. So acute infections usually occur when the symptoms are less than 2 months, whereas chronic, it is 2 months. So it's simple. This is a paper by Curie et al., and this is how they define it. Now this same paper, they actually studied 540 confirmed melioidosis patients, culture confirmed, right? And they prospectively studied them over 20 years, and this was done in Northern Australia, Darwin, Royal Darwin Hospital, and the results were 89% of the patients over this 20-year prospective study were actually presenting with acute illness. That's 89% of them, and the other chronic illness was made out of 11%, and majority of those in the chronic illness actually had pneumonia and a non-healing skin. So the next question is, what's a latent infection with reactivation? So in endemic regions, you can get a latent infection 19 to 24 years later, example in Australia, right? So in this paper, Curie has also, this same paper that I quoted earlier, okay, Curie et al., he has said that 4% were felt to be reactivation of Burkholderia pseudomoli from the latent foci in his 20-year prospective study. So I'll share a case with you. This is a 45-year-old male, works in a factory, has history of cough, fever, muscle aches and pains, loss of appetite, loss of weight. All the symptoms for about 2.5 months. So now, if going by the symptoms with this chest x-ray and the blood investigations as shown here, with a hobby which shows gardening. Tuberculosis B? Tuberculosis? possible. In Malaysia, anything is possible, right? Anyway, since I'm talking on melioidosis, it has to be pulmonary melioidosis. Now, if you go by the definition, then he has a chronic melioidosis, right? All right, now let's look at this. Acute infections, they present with high fever, cough, sputum production, chills, rigors, and respiratory distress with or without shock. Whereas in chronic infection, they have cough, a purulent sputum production, hemoptysis is more likely, and night sweats with mimicking TB. Clinical presentation and medical management of melioidosis in children. In this prospective study, or 24-year-old prospective study, adults actually had pneumonia of 54% and bacteremia of 16% versus children who had most cutaneous skin inoculation of 60%. And usually these cutaneous inoculations were actually more specific inoculating events, and most of these children had no recognizable risk factors. This is in contrast with adult patients who have all the risk factors, right? So I will share with you a case of cutaneous melioidosis. This case was reported in a 50-year-old Swedish male traveler who was caught up in Thailand during the tsunami in 2004. So during that event, he was washed by the flood waters for around a kilometer, more than a kilometer distance, and in the process he suffered multiple laceration wounds, and subsequently when he was rescued, he had these wounds debrided, and he was given IV and then oral antibiotics and discharged well. And he left Thailand and arrived in Sweden on the 1st of January 2005. However, at that point when he arrived in Sweden, he was well, the wounds were healing well, and there was no symptoms or signs to indicate that he was actually having melioidosis. However, on the 31st of January 2005, he first noticed a small abscess appearing on the right first toe, web of the first toe, and he went and sought treatment, and subsequently the doctor did IND and sent the pus for culture and sensitivity, and he grew Burkholderia pseudomoli. However, his serology that was taken at that same time came back negative. So he was treated with IV and then oral medication for Burkholderia pseudomoli, and he recovered well. Right? Now, just to share the other presentations that can be found, or skin presentations or cutaneous presentations of melioidosis. All right, patients present with what you call ulcers or abscesses. All right, like in this Darwin study, the same Curie-Darwin study that I showed earlier, of the 540 cases culture confirmed melioidosis, 28% were actually without bacteremia who presented with skin ulcers or abscesses. Okay, and frequently they come with a history of failed to respond to oral antibiotics administered prior to admission. Rarely they got anyone with diffuse cellulitis. But what is important is, if you look at these lesions, this could mimic many other common skin conditions, such as psoriasis. Could it be mycobacterium, non-tuberculous mycobacterium infections like abscesses or chelonae or fortuitum? They can also present non-healing ulcers like this. Or you could get cutaneous ulcers such as this, which could also be a form of tuberculosis or NTM, or it could also be any other any organism causing this abscess. Alright, let's look at the clinical features. Again, I have quoted them based on different countries. Alright, so if you look all the countries, Australia, Thailand, Malaysia, and also the two states that gave data, the Kedah and Terengganu, majority of their patients presented with a pneumonia. Genital urinary abscess, mainly prostatic abscess, was seen predominantly in Australia, right, and the others in Thailand. Parotid abscess seen mainly in Thailand, but the rest didn't seem to report that. And CNS encephalitis, I think it is under picked up. It is not commonly looked for and is mainly missed. That's why I feel it's underreported, but keep in mind melioidosis can present as a with CNS involvement as well. Now let's look at splenic abscess. Yes, Kedah and Terengganu seem to have lots of splenic abscess, and also liver abscess. Both these states have given a lot of data on that. Okay, and soft tissue. Okay, soft tissue abscesses. Okay, it seems to be pretty same across the. So this is a poster that was put up by ID in Hospital Tengku Ampuan Rahimah. It was supposed to be presented during the ICID meet in February this year in KL. Unfortunately, due to COVID, it got postponed. So we looked at our melioidosis registry, and we had data from 2017. We picked up data from January 2017 till December 2018. So over a 24 months period, we had diagnosed a total of 38 cases of culture confirmed melioidosis. And of these 38 cases, 26% of them ended up as mortalities. And if you look at the breakdown of how they presented, we had 39% who were pneumonia, 26% soft tissue abscesses, and 23% actually did not have any foci of infection. So this is a small study that was done in my hospital, but we are looking at expanding this till maybe end of this year, and then writing another paper on. So what kind of tests can we send for melioidosis? So in all patients with suspected melioidosis, the following samples should be sent. I'm not saying send all these samples in one patient, but what I'm saying is send as many samples as possible in your patient to ascertain the diagnosis. So you can send blood, sputum, urine, swab from ulcers or skin lesions, abscess fluids, and then also throat swabs, rectal swabs, or CSF. Now, what is important is when we send the blood culture, right? Please ensure that adequate amount of blood is put into the Bactrim bottle. Otherwise, you may not obtain a growth of the organism. So when we talk about culture, it becomes the mainstay of diagnosis. So isolation of Burkholderia pseudomoli from any sample is highly likely to represent a true infection. So sometimes when we send samples, we get maybe a blood sample, but there's a nice skin lesion which is sitting there, but nobody swabs that lesion or the ulcer to send for culture. So always remember, even though the site may actually lack some signs of active inflammation, if you feel suspicious of it, do take the cultures and send, because it may have a positive culture result, and that will help clinch the diagnosis. And as I mentioned earlier, ensure adequate amount of blood is put into the culture bottles. Otherwise, you're not going to get a positive yield. And always remember, the recommendation is between 8 to 10 ml of blood in your Bactrim bottle for you to get a positive culture. The other test commonly sent is serology. So how reliable is serology for melioidosis? Unfortunately, it's not a reliable method when used as a standalone test, okay? Because the interpretation of serology becomes very difficult, especially if you are living in an endemic area like Malaysia, because there is already a high background seroprevalence rate. So there's a lot of incomplete understanding of the time frame for melioidosis antibody response, and also that's recurrent exposure, so it's very hard to interpret serologies. The other issue is the relative importance of IgM and IgG. It's not clear, it's really unclear at this. And then the most common serodiagnostic test that we use is indirect heme agglutination assays that we have, and also ELISAs. So usually the cutoff titer is about 1 in 40 to 1 in 60. Now this is a huge range, and if you take usual recommendations, they say PET sera demonstrating a 4-fold rise in the antibody titer. However, if you follow IMR, their serological methods are a little different. They actually use a cutoff of 1 in 320. This is because they base it on the background seroprevalence rate, and this data is obtained from blood donors. So in essence, right, a sero-diagnosis in melioidosis is in an endemic setting like ours has limited value lah. And serological tests are at best adjunct to a culture-based diagnosis, and it cannot be recommended for routine diagnosis in endemic areas. And we also don't know if we can use the serological test for post-treatment what you call monitoring, because we don't know post-treatment baseline titers, how to interpret it. So if we look into other tests that can be done, right, besides bloods and cultures from swabs and whatnot, I think one of the most important test is imaging using a chest X-ray. So any patient who is suspected to have melioidosis, okay, should have a chest X-ray done, and this will certainly help to rule out if there's any pulmonary involvement. And in this paper from in 2014, the revised Royal Darwin Hospital guideline, if you look at what they have said, I think this is one of the most important what you call recommendations that I view it as one of the most important recommendations. They say that in any confirmed melioidosis cases, culture confirmed that is, a CT or ultrasound of the abdomen and pelvis is required to detect any internal abscess irrespective of clinical presentation. And I totally agree. Many a times, as I showed you data earlier, that we need to really look hard for internal organ, or soft tissue, or abdomen or pelvis collections or abscesses. If we don't, we will miss a prostate abscess, we will miss a spleen having abscess, we will not treat the patient adequately. I think it is very important. This recommendation should be taken into our clinical practice and done routinely. So I really like this recommendation from the Royal Darwin Hospital, where all patients with suspect melioidosis should have a chest X-ray, and if it's culture confirmed melioidosis, then we must do either a CT or ultrasound of the abdomen and pelvis to detect. So finally, we arrive at treatment. So treatment is divided into two phases, the intensive therapy and the eradication therapy. So in intensive therapy, the aim of the intensive therapy is to reduce the mortality from severe infections. At least the duration that we are aiming at is at least 2 weeks of intravenous therapy. I will explain more as we go along. And in the eradication therapy, we are actually looking at using oral antibiotics for a more prolonged period. Again, I'm quoting the Royal Darwin Hospital guideline of 2014. Alright, so the initial intensive therapy, the choice of antibiotics is ceftazidime. However, if your patient is very ill, in septic shock, and requiring ICU stay, they give you the option of using meropenem, carbapenem, okay, upfront. Alright, and the doses are as what has been mentioned. Now, very important to know, if you're dealing with neurological melioidosis, or if your index of suspicion is high that there is a neurological melioidosis, please start off by using a carbapenem, meropenem upfront, and the dose is usually doubled to 2 grams and is given over 8 hourly in a day lah. Alright. The other thing that I want to bring your focus on is the eradication therapy. Usually it's required after the intensive phase. Now the doses used, they have standardized the dose to be similar or consistent with those used in Thailand, because Thailand showed pretty good outcomes using this dose of trimethoprim and sulfamethoxazole. In adult patients, they use 40 to 60 who are 40 to 60 kilos. They used about 240 milligrams of trimethoprim and 1200 milligrams of sulfamethoxazole. It comes up to average of about 2 to 3 tablets lah, depending whether you are less than 60 kilos or more than 60 kilos. And usually the eradication phase is for about 3 months. And don't forget to add on your folic acid. So quoting the same Darwin guidelines, right? we look the recommendations is based on the presentation, and if you look at their recommendations for patients who have skin abscess, bacteremia with no focus, and pneumonia without lymphadenopathy or without ICU stay, 2 weeks of intravenous antibiotics during the intensive phase is sufficient. However, if your patient has a pneumonia with either a lymphadenopathy or an ICU admission, then the duration changes. It becomes 4 weeks of intensive phase, 4 weeks of IV antibiotics during the intensive phase. And if the patient has a deep-seated collection or a septic arthritis, it's again 4 weeks of intravenous antibiotics. However, if the patient has osteomyelitis, it's 6 weeks, and CNS infection, it is 8 weeks of intravenous antibiotics. Even the eradication phase, the duration is different. For all conditions except osteomyelitis and central nervous system infections, every other condition is actually 3 months. But for osteomyelitis and CNS infections, the duration of eradication phase is prolonged to 6 months. So this is actually a table that has been put up in the same paper, and they talk about dose adjustments in patients with renal impairment, and it is the recommendation for the 3 commonly used antibiotics, ceftazidime, meropenem, and Bactrim. So one of the common questions we get asked is how do you calculate the dose, or what dose of Bactrim do we use? So in this slide, I will highlight that. So if you are having a patient who's more than 60 kilos, you will need about 320 milligrams of trimethoprim 12 hourly. So what you need is to use 320 milligrams, you have to divide it by 80 to get 4 tablets. So basically in 1 tablet of Bactrim, there's 80 milligrams of trimethoprim. So when you use Bactrim, the intravenous formula and the oral formula, it's a direct conversion. So if you require 5 ampoules a day, it's equivalent to 5 tablets a day. So the eradication therapy is required after the intensive therapy. Now the doses that are used is trimethoprim plus sulfamethoxazole in an adult patient who is 40 to 60 kilogram. The trimethoprim dose would be around 240 milligrams, whereas in an adult who is more than 60 kilogram, you will require 320 milligram of trimethoprim, and this is to be dosed every 12 hours for at least 3 months, or according to the chart that I showed you earlier, if you have osteomyelitis or if the person has a CNS manifestation, then it will be for 6 months. Now, what are the side effects of Bactrim? Okay, rashes, pancytopenia, hyperkalemia, RTA can occur, and also hepatitis, but the commonest is still rashes lah. And if you are getting a patient coming in with rashes, and you know, if the rash is getting worse and there's ulcers, please stop the medication and monitor your patient, because Bactrim allergy can be very severe. It can lead to Stevens-Johnson's, and it can have very bad outcomes as well if we do not recognize the problem early and stop the medication early. Okay, the next question that is asked is, when do we add Bactrim? All right, so for neurological melioidosis, osteomyelitis, septic arthritis, or genitourinary infections, right? This includes prostatic abscess, skin and soft tissue infections. You can add the trimethoprim sulfamethoxazole from the commencement of therapy in the eradication doses lah. All right, so that means you can add these for these conditions, for this kind of presentations, you can add them in at the beginning of your intensive phase itself, but you use the same dose as you would use in the eradication phase. Okay, so now the next question that we get asked is, what do we do if the patient is intolerant to Bactrim or he has allergy issues? So according to, if we look at our National Antibiotic Guideline 2019, the recommendation is to use amoxicillin clavulanate, but the dose is different than your normal dosing of amoxicillin clavulanate. So if you look at this table, it shows that if your patient is less than 60 kilos, you would use 2 tablets of 6 to 5 milligrams every 8 hourly. And if your patient is more than 60 kilos, you will use 3 tablets of 6 to 5 milligrams every 8 hourly. So remember, the dosing is different. It's not your normal augmentin dose that you use 1 tablet TDS or 1 tablet BD. It doesn't work. You need to use a higher dose, and you need to dose it by the body weight, according to the body weight of your patient. Alright, so this is a very nice paper. Alan C. Cheng et al. Authored this paper. Basically, they look at all the different combinations used for eradication phase. They looked at amoxicillin clavulanate versus chloramphenicol, doxycycline, trimethoprim. So they've given, doxy alone versus chloramphenicol and doxy and Bactrim, or azithrocipro versus doxy and Bactrim. So all the combinations. So what you can see, right, many of these combinations don't work, but the one that showed or was most promising with the minimum relapse rate was the study by Chawagul et al., where they showed doxycycline and Bactrim versus chloramphenicol and doxy and Bactrim. This showed promising results where doxy and Bactrim actually brought down the relapse rate to only 5.6%. So I'll elaborate more on this. So doxycycline, if it's used, it has to be used at a dose of 100 milligrams twice a day or 200 milligrams once a day. It's actually an alternative to trimethoprim sulfamethoxazole. However, it is less effective than Bactrim. All right. So now Bactrim versus Bactrim with a placebo versus Bactrim plus doxycycline as an oral eradicative treatment for melioidosis. It is a multi-center, double-blind, non-inferior, randomized controlled trial that was done in 5 centers in northeast Thailand. And they recruited all culture confirmed melioidosis into this study. They randomly assigned them into the 2 groups, either a Bactrim plus placebo or Bactrim plus doxycycline for 20 weeks. What they found is of the 626 patients who were actually recruited, 311 of them were in the Bactrim plus placebo arm, while the other 315 of them were in the Bactrim plus doxycycline arm. And if you look at the results, okay, 5% of those in the Bactrim plus placebo group actually developed a recurrent, culture confirmed recurrent melioidosis versus 7% of those in the Bactrim plus doxycycline group. Alright, so what it shows is, in this study, they have shown you that Bactrim is actually non-inferior to Bactrim plus doxycycline for the oral phase of melioidosis treatment. So on this basis, Bactrim is actually a preferable choice because, number one, it is also considered safe, and it is and more patients are actually tolerant to the drug compared to those who have to take Bactrim and doxycycline. They had more side effects, right? So in this study, Bactrim was shown to be non-inferior, hence the recommendation for Bactrim as monotherapy. Alright, so now looking at amoxicillin and clavulanate, it's actually less effective in preventing relapses. It is recommended for eradication therapy in pregnancy in Thailand in their guidelines if the patient was Bactrim intolerant. So patients who their first choice was still Bactrim in pregnant ladies, but if they were intolerant to Bactrim, they actually gave them amox clavulanate, and the dose they use is pretty high dose, 20 amox and 5 milligrams of clavulanate clavulanate. But however, please take note, okay, this study found this study by Smith et al., they found that there was higher relapse rate and poorer adherence due to intolerance actually. So this is a major downfall of this yeah. Uh, the other question that I find commonly comes up is, do we use GCSF? Do we use granulocyte colony stimulating factors for treatment of a severe sepsis due to melioidosis? All right, do we use it? Well, this study is a randomized controlled trial again done in Thailand. Many good studies from Thailand. They showed by actually using this GCSF, they managed to reverse the neutrophil dysfunction. They feel it's either reversing the neutrophil dysfunction or actually the anti-inflammatory effect came into play, and they actually dropped mortality from 95% to 10% in northern Australia. Okay, so there were two studies, okay, that were done, and this was actually adopted by the Royal Darwin Hospital for all melioidosis patients. Okay, now looking at the dose and the contraindications for GCSF, okay, the dose used is 300 micrograms daily, or recommended is 300 micrograms daily, and the duration is 10 days or total duration of ICU stay. Now you tailor these according to the clinical response of the patient. So if your patient is improving and your patient can leave ICU, patient is well, you do not need to continue the GCSF. Now in this paper also, the absolute contraindication was actually only acute coronary syndrome. The others, they still gave them, even those with liver derangement, they used okay. Now I would like to share with you this randomized control trial that was done in Thailand, looking at GCSF use in the treatment of severe sepsis due to melioidosis. So it was authored by Chang et al. And this paper actually showed that the patients, those patients who received GCSF actually had lower 28-day mortality, and the duration of survival increased with GCSF. Okay, so let's look at the key to treatment success. I think it is really important imaging, the correct imaging is done, and we must get the imaging done soon as possible because we want to detect deep-seated abscesses. We should drain any abscesses, and we should keep the right choice of antibiotics with the right dose and the right duration. And number 4, we have to ensure compliance. So we have to counsel the patient and their family members and make sure that they complete their intensive phase, and more so the eradication phase, because usually due to the pill burden and also the long duration, patients tend to default. Okay, so in summary, Burkholderia pseudomoli is actually a gram-negative bacteria. It's an environmental saprophyte, and diabetes has been recognized as one of the major risk factors for melioidosis. More than half the patients with melioidosis have a bacteremia, but that means we also have to look, besides bacteremia, we also have to look for pneumonias, deep-seated abscesses, and imaging would certainly help to look for deep-seated abscesses. And don't forget, culture is the mainstay for diagnosis, and aim to drain any abscess where possible. And the treatment has two phases, the intensive phase and the eradication phase. And always remember to talk to your patients on compliance to treatment. Okay, with that, I thank you.